Good evening. Tonight we start with a story that doesn't settle easily. It's the story of fentanyl, a compound engineered under clean laboratory lights, introduced as a surgical marvel, and later blamed, sometimes accurately, sometimes lazily, for a public health nightmare measured in breaths that stop too soon. If you came here for a simple morality play, I'm going to disappoint you. There's no neat line between salvation and ruin in this history. What you get instead is a braid of science, commerce, policy, and human need, tightened over decades until it became difficult to separate the strands. And this is not ancient history. If fentanyl reaches an unregulated supply on your street, it doesn't behave like other drugs. It rewrites the margin of error. It makes a little too much into too late. For some families, that reality isn't theoretical. It's a voicemail they can't delete, a jacket still hanging by the door, a date they won't say out loud. Before we go further, if you genuinely like what we do at the Forbidden Dispensary, you can support the channel, like the video, subscribe, and tell me in the comments where you're watching from and what time it is for you. I always find it grounding, in a strange way, to see how many different nights are happening at once. Now silence the notifications. Take a breath, let the room get quiet, because the story begins quietly too. In the late 1950s, on the outskirts of a small Belgian town, a lab team worked with the patient intensity that defines real chemistry. Not explosions, not genius monologues, but careful weighing, controlled temperatures, slow crystallizations, and the kind of note-taking that turns a week of work into a single usable result. At the center of that effort was Paul Janssen, a physician and pharmacologist who understood something that would shape the entire pharmaceutical century. Molecules don't change medicine until somebody builds systems around them. Manufacturing, testing, distribution, marketing, regulation, training. Chemistry is the seed, industry is the soil. The post-war era was fertile ground. Europe had learned through tragedy how urgently modern medicine mattered. Governments funded research, industry scaled up production. Antibiotics were transforming infections from death sentences into inconveniences. Sedatives and psychiatric drugs were reshaping hospitals. Blood banking, anesthesia, intensive care. Whole disciplines were expanding at once. Pain management in that world was both a clinical problem and a moral one. Surgery was becoming more ambitious, more invasive, more survivable, and that meant pain control couldn't be an afterthought. It had to be precise, fast, and predictable. Janssen's group explored synthetic opioids the way a locksmith explores a set of keys, by adjusting tiny shapes until one fits the lock with unsettling perfection. They weren't chasing intoxication, they were chasing control. An opioid that could be used in anesthesia with speed and reliability, an analgesic that could blunt the body's stress response during surgery, a drug that anesthesiologists could titrate without wrestling the patient into a fog that lasted half the day. And they were working within a chemical family, a scaffold that could be modified like a chassis swap one part, add another, change how the molecule moves through fat, blood, brain. The goal was not only potency, it was behavior, how quickly it entered the central nervous system, how sharply it hit, how manageable it was minute to minute. One of the decisive properties was lipophilicity, fat-loving chemistry. The more a compound prefers lipid membranes, the easier it can slip through the biological barriers that keep most things out of the brain. That one trait, how comfortable a molecule is moving through fatty tissue, can decide whether a drug takes effect in minutes or in an hour. In those years, that kind of optimization felt like progress. It was progress. When a patient is on an operating table, fast and predictable are not marketing words. They're survival words. Fentanyl emerged from that effort as a molecule that did exactly what it was designed to do: bind powerfully to the mu-opioid receptor and produce profound analgesia at extremely small doses. In a controlled setting, that potency is a gift. It means less volume, less histamine release than some older opioids, fewer hemodynamic swings. It means a surgeon can operate while the body stays quieter. But potency is never only a gift. Potency is also a liability that waits for context, because when a drug works in micrograms, when a dose can fit on the head of a pin, the safety of the entire system starts depending on the weakest link. A mislabeled vial, a distracted calculation, a patch left too long in the heat, a counterfeit pill pressed with uneven powder distribution, an unsuspecting person taking what they think is something else entirely. On paper, the pharmacology looks straightforward. Receptor binding, signal inhibition, reduced neurotransmitter release, pain muted. In life, it's not that clean. The same receptor action that reduces suffering can also suppress respiration. The same speed that makes it useful in anesthesia can make it unforgiving outside of medical supervision. And that's the hinge the whole story turns on. Fentanyl doesn't become a crisis simply because it exists. It becomes a crisis when it escapes the controlled environments it was built for, when it meets systems that aren't designed for microgram precision, and people who don't know they're handling something that doesn't tolerate guesswork. In Part 2, we'll get practical. We'll talk about what fentanyl does at the receptor level in human language. Not as a lecture, but as a map. Why it hits so fast, why it redistributes, why patches behave differently than injections, why the line between effective and fatal can be so thin that it barely deserves to be called a line at all. Let's keep the stylization then. We'll stay with the rough edges, the slightly off spelling, the told at night cadence, because the story itself is rough-edged, and because the details matter more than polish ever will. Now we move from the lab bench to the body. At the molecular level, fentanyl is brutally efficient. It doesn't negotiate with pain, it interrupts it. The compound is a full agonist at the mu-opioid receptor, the same receptor family that older opiates target, the same biological doorway that can quiet suffering and, in the same motion, quiet the instinct to breathe. That receptor isn't poetic, it's mechanical. A G-protein-coupled receptor sitting in cell membranes, especially in parts of the brain involved in pain processing and in the brainstem where the rhythm of breathing is regulated. When fentanyl binds, it triggers a cascade that looks clean in a textbook and dangerous in a living room. The chain reaction, simplified but not fictional. Activation of GIO proteins, inhibition of adenylyl cyclase, a drop in cyclic AMP, potassium channels opening, calcium channels closing. The neuron becomes less excitable, less neurotransmitter gets released. Pain signals lose their volume. The body's alarm system gets turned down. In the operating room, that is clinical music. In the wrong context, it's silence. Because the other half of the same mechanism is respiratory depression. The same receptor activation that dulls pain also dulls the brain's response to rising carbon dioxide. The body stops insisting on breath. The chest rises more slowly, then it may not rise at all. Clinicians have always known that opioids carry this risk. Fentanyl didn't invent the trade-off, it sharpened it. It concentrated the consequences into smaller amounts and shorter windows of time. If morphine asks for caution in milligrams, fentanyl demands precision in micrograms. The decimal place stops being a detail and becomes the difference between a controlled anesthetic plan and an emergency. So why does fentanyl feel so fast? Why does it seem to arrive in the brain like a shadow? Two properties do most of the work: structure and lipophilicity. Fentanyl's architecture makes it unusually comfortable moving through lipid membranes. That fat-loving behavior helps it cross the blood-brain barrier rapidly, especially when delivered intravenously. In a clinical setting, that's useful. In an uncontrolled setting, it means a person can go from awake to collapsing in minutes, sometimes before anyone around them understands what's happening. Potency is not just a marketing word here, it's a measurable relationship between a tiny amount of drug and a large physiological effect. Depending on the comparison and the model, fentanyl is often described as 10s to roughly 100 times stronger than morphine. In practical terms, that means the dose that produces analgesia is so small, it can be hard for the human mind to respect it. We aren't built to fear specks. We're built to fear piles. Fentanyl punishes that instinct. The The pharmacokinetics, how the body handles the drug over time, adds another layer of nuance that matters for both medical use and misuse. After an intravenous bolus, the effect can be rapid and intense, but it may not last long in the way people expect. Not because the drug vanishes, but because it redistributes. Early on, fentanyl concentrates in the brain and blood. Then, because it's lipophilic, it moves into muscle and adipose tissue. The brain effect fades as the drug leaves the central compartment and settles into peripheral stores. To an anesthetist, this can be a feature, a short, controllable window that can be repeated and titrated. To someone outside medicine, it can be a trap. The high arrives quickly, seems to fade, and encourages redosing, while the body's overall burden quietly accumulates. Continuous infusions change the picture again. When fentanyl is administered over time, especially at higher doses, it can build up in fat and then leak back into the bloodstream. The drug that seemed short-acting during a single bolus becomes longer and less predictable during prolonged exposure. Clinicians know this. They plan around it. They watch ventilation. They adjust and anticipate. Outside the clinic, there is no such monitoring, and the delayed return of drug from fat stores can be a nasty surprise. Metabolism matters too. Fentanyl is largely metabolized by the liver, primarily through CYP3A4, into inactive metabolites like norfentanyl. That enzyme detail sounds academic until you remember how many common medications inhibit or induce CYP3A4. Some antibiotics, some antifungals, certain antiviral agents, even grapefruit-related interactions, small biochemical pushes that can increase fentanyl levels or alter its clearance. In a hospital, pharmacists and clinicians try to account for those variables. In the real world, polypharmacy and unknown substances make the risk harder to predict. And then there are the clinical quirks that reveal, in a flash, how powerful this compound really is. One phenomenon that still unsettles people the first time they see it is chest wall rigidity, sometimes called wooden chest. Administer fentanyl rapidly, especially at higher doses, and a patient can become rigid in a way that makes ventilation difficult. Not because they're fighting, not because they're awake and resisting, but because the drug can induce a muscular stiffness that turns the chest into something mechanically uncooperative. It's treatable neuromuscular blockers, careful dosing, time. But the image sticks. A drug strong enough to quiet pain, also strong enough to change the mechanics of breathing itself. Routes of administration shape how fentanyl behaves, and this is where the story begins to spread into the wider world. Oral dosing is relatively inefficient because of first-pass metabolism. The liver gets a first swing at the drug, reducing what reaches systemic circulation. That's why fentanyl's clinical expansion leaned into other routes: intravenous for speed and control, neuraxial routes for regional analgesia, transdermal for steady chronic delivery, and transmucosal routes for fast breakthrough relief. Intravenous use was the natural first home. It fit anesthesiology's requirements: rapid onset, predictable titration, a drug that could be layered into balanced anesthesia. In the 1960s and 1970s, fentanyl helped rewrite parts of the anesthetic script. It blunted surgical stress responses with less histamine release than morphine. It offered hemodynamic stability that became especially valuable in cardiac anesthesia, where blood pressure swings aren't just inconvenient, they're dangerous. Neuraxial uses followed. Epidural and spinal administration took advantage of fentanyl's properties in the cerebrospinal environment. Its lipophilicity means it tends to act more locally and with less rostral spread than some hydrophilic opioids. In obstetrics, for example, it could provide potent analgesia for labor, with relatively rapid onset when combined in spinal epidural techniques. Again, clinically elegant, but dependent on trained monitoring and exact dosing. Then came the delivery systems that changed the everyday experience of pain management: the patch and the lozenge and the sprays. Transdermal systems exploit a different logic. Instead of peaks and troughs high dose, then fading, they create a depot in the skin that releases fentanyl steadily over hours and days. For chronic pain patients, especially those in palliative care, that steadiness can feel like a small rescue. It reduces the ritual of repeated dosing. It smooths nights that might otherwise be interrupted by pain. It makes care more manageable in homes and hospices where resources are limited. But depot behavior has a shadow side. Changes in dose aren't immediate. Heat can increase absorption. A patch left in place too long, applied incorrectly, or combined with external heat sources can deliver more drug than intended. Even used patches may retain significant active compound, creating a disposal and diversion problem. The same design feature that makes the patch dignified and discreet can also make it stubbornly unforgiving when misunderstood. Transmucosal formulations, lozenges, buccal tablets, sublingual sprays, nasal sprays bypass much of first-pass metabolism by using the vascular beds of the mouth and nose. They can deliver fast relief for breakthrough pain, which is a very real phenomenon in cancer care and other severe pain conditions. Stable baseline pain control punctuated by sudden flares. These formulations were built to answer that problem. They were also, inevitably, built in a way that could be attractive to misuse. Small, portable, rapid onset. This is the pattern you'll see again and again. A legitimate clinical need leads to an innovation. The innovation solves real suffering. The same innovation creates new failure modes when it moves into broader circulation. As fentanyl's footprint expanded operating rooms, ICUs, emergency departments, hospice bedrooms, medicine had to learn new habits. Micrograms became a working unit in daily practice. Decimal discipline became a cultural requirement. Inventory systems tightened. Pharmacists warned about CYP3A4 interactions. Nurses learned to account for patches the way they accounted for controlled vials. Protocols were written, revised, rewritten, and yet for decades, the story most clinicians told themselves was a pragmatic one. Fentanyl worked, and when used correctly, it could be managed. A triumph of pharmacology applied with respect, a tool that eased suffering. That narrative wasn't entirely wrong. It was incomplete, because the same qualities that made fentanyl valuable, speed, potency, reliability, also meant that when the drug moved beyond tightly controlled settings, the consequences of small errors could become enormous. A molecule designed for precision would eventually demand precision from every system it touched, and not every system was built to deliver it. In Part 3, we'll follow the molecule out of the clinic's inner rooms and into the world of products. How formulation and packaging changed the market, how patch technology and transmucosal breakthrough solutions were developed, and how the language of pain, policy, and promotion began to widen the circle of exposure. The next chapter isn't really about chemistry. Not directly. It's about what happens when a molecule leaves the bench and becomes a product, when it moves from a controlled clinical tool into an object that can be ordered, stocked, shipped, branded, and eventually mishandled. The active ingredient stays the same. The context changes, and context is where outcomes are born. By the 1960s, fentanyl had found its place in anesthesia. In many hospitals, it was spoken of the way clinicians speak about equipment that does its job, with a kind of quiet respect. Small doses, fast onset, predictable effect, controllable, the word anesthesiologists love because it suggests mastery in a setting where mastery is always borrowed time. But the major commercial leap, the one that reshaped how ordinary people encountered the molecule, was less about what fentanyl was and more about how it could be delivered. In the 1980s and into the early 1990s, controlled release technology matured. Companies that specialized in drug delivery systems refined adhesives, membranes, laminated layers, and reservoirs designed to move an active ingredient into the bloodstream at a steady, measurable rate. Not a bolus, not a rush, a drip you could wear. When the transdermal patch arrived, it promised a particular kind of relief, steadiness. For chronic severe pain, especially in cancer and end-of-life care, steadiness isn't a luxury. It's what makes sleep possible. It's what makes a day livable. The patch offered a quiet practicality therapy measured in micrograms per hour, changed every few days, reducing the need for constant pills, injections, or complicated schedules. To patients, it could feel like dignity. To clinicians, it could feel like rational pharmacotherapy. Stable plasma levels, fewer peaks and valleys, a route that sidestepped the problem of swallowing, nausea, or erratic absorption. To caregivers, it could feel like a small simplification in a life that had become nothing but appointments and medication alarms. And to a company, it could feel like opportunity. This is where we need to speak plainly, without melodrama. The pharmaceutical industry is not only a scientific enterprise, it's also a commercial machine. And commercial machines follow patterns. One of the oldest patterns is repackaging. Take an active ingredient with proven value, then develop a new delivery system that opens a broader market, extends patent life, and creates a new narrative of innovation. A patch can be positioned as modern. A spray can be positioned as precise. A lozenge can be positioned as patient-centered. A family of formulations can be positioned as a complete solution, covering baseline pain and breakthrough pain with different tools built on the same potent core. In that era, fentanyl became more than an anesthetic. It became a platform. The manufacturing side of this story is technical, and because it's technical, it tends to be ignored. That's a mistake. Technical details become public health realities when millions of units enter circulation. Pharmaceutical plants operate under good manufacturing practice, GMP standards. In theory, that means rigorous control of active pharmaceutical ingredients, solvents, contaminants, batch records, stability testing, and chain of custody. A patch is not just drug on tape, it's engineering. Adhesives must hold to skin without causing failure. Membranes must release drug at predictable rates. Packaging must prevent moisture and degradation. Labels must be unambiguous because the dosage unit is unforgiving. Transmucosal products come with a different set of challenges. A lozenge or tablet needs consistent dosing and predictable dissolution. Sprays require reliable atomization and metered delivery. Flavoring and excipients aren't cosmetic details. They change adherence, absorption, and misuse potential. These are complexities that tend to favor large, well-capitalized companies because doing it at scale with quality control is expensive. But over time, as more products enter a market, more points of failure appear too. You can't scale a potent opioid into multiple consumer-friendly forms without also scaling the number of ways it can be misunderstood, diverted, or exploited. That isn't moralizing. It's systems thinking. Every new format is a new interface between a dangerous compound and ordinary human behavior. Around the same period, a broader cultural shift was taking shape, especially in North America, one that would alter how pain was discussed and treated. Pain began to gain institutional weight. Hospitals were encouraged to assess it more routinely. The idea that pain should be measured, charted, treated aggressively framed, almost as a moral imperative spread through clinical culture. Pain as the fifth vital sign became a phrase with a long shadow. In some settings, clinicians were made to feel that unrelieved pain was evidence of inadequate care, even when the clinical picture was complex. This shift did not come from one source. It was an atmosphere, patient advocacy, professional societies, accrediting bodies, and yes, industry messaging moving in the same direction. That's the hinge again. A legitimate problem undertreated pain met a set of incentives that made opioid solutions feel obvious, modern, and compassionate. In that environment, the boundaries that once kept fentanyl tightly confined to specific indications could begin to loosen at the edges. Marketing lives in edges. It doesn't usually argue by lying outright. It argues by emphasis, by framing, by selective simplicity. The themes were familiar: steady control, fewer peaks and troughs, rapid onset for breakthrough episodes, improved quality of life. The language of patient-centered care and restored function blended easily with the appeal of products that looked clean and precise. A patch seems clinical, a metered spray seems engineered, a lozenge seems measured. All of it can feel safer than a bottle of pills. Meanwhile, the industry's machinery of influence sales reps, sponsored education, symposia, funded continuing medical education, operated the way it always has. It's not unique to fentanyl, but fentanyl products benefited from it because they were easy to present as innovations. New delivery, new convenience, new niche. The niche that mattered most was breakthrough pain. Breakthrough pain is real. It's also an opening, commercially. If baseline pain is controlled by a patch, then you can sell a second product for the flare-ups. If a patient can't swallow, you can sell a spray. If you want rapid onset without injections, you can sell a tablet that dissolves in the cheek. Each step seems sensible, and often it is. But the stepwise logic also expands exposure. More products, more prescribers, more points of contact between a high-potency opioid and the broader public. And not all promotion stays within the strict borders of indications. That's where things begin to darken. When a drug is approved for a narrow population opioid-tolerant cancer patients, for example, but a sales culture begins to treat it as part of everyday pain management, the safeguards weaken. The product is the same, the patient population is not. And fentanyl is not forgiving about that mismatch. It's also worth understanding the quiet practical problems that followed certain products as they entered the world. Heat increases transdermal absorption. That means a heating pad, a fever, a hot bath, ordinary things can become variables in dosing. Used patches can still contain a substantial amount of active drug, turning trash cans and medicine cabinets into inadvertent sources. People learned quickly and grimly that a patch designed for slow release can be cut, chewed, soaked, heated, or otherwise abused to force a faster delivery. Transmucosal products prized for rapid onset in legitimate care also offered something else in the wrong hands. A quick jolt, easily concealed, easily transported, easier to divert than an IV vial locked in a hospital cabinet. Regulators tried to push back over time-tightened labeling, restricted distribution programs for certain high-risk formulations, educational requirements. But these measures often moved after the fact, after prescribing patterns had already widened, after diversion pathways were established, after the notion of fentanyl as a solution had seeped into broader practice cultures. And all of this was still, in many people's minds, a story about medicine. Then the molecule's family tree began to grow in two directions at once. Legitimate analogues developed for clinical precision, and shadow analogues improvised to evade law and maximize profit. On the legitimate side, anesthesiology gained tools with names that never became household words, compounds engineered for specific timing, potency, and metabolism, designed to be shepherded by monitors, ventilators, and trained clinicians. These were controlled instruments. On the other side, the illicit world discovered something the clinic had always known. Tiny chemical tweaks could produce new analogues with powerful effects, and sometimes with properties that made them harder to detect, harder to regulate, and deadlier in the uncontrolled supply. That's where we go in Part 4. We'll talk about the analog explosion, how a single scaffold can be modified into a parade of compounds, how policy tried to keep up with a chemistry that moves faster than legislation, and why the transition from diverted pharmaceuticals to industrial-scale illicit synthesis changed the overdose landscape so sharply that the old playbook stopped working. A molecule like fentanyl doesn't travel alone for long. Once chemists learn a scaffold, once they understand which parts can be changed without breaking the core effect, they begin to improvise. In legitimate medicine, that improvisation is disciplined. It happens in regulated labs, under protocols, with clinical trials, dosing studies, monitoring standards. In the illicit world, the improvisation is opportunistic. It happens in makeshift rooms, with uncertain reagents, under pressure to evade laws and maximize profit. Both worlds share the same basic insight. Small structural changes can produce big consequences. In the clinical lineage, fentanyl's cousins were designed as tools. Some were built to be even more potent, useful in very specific anesthetic techniques. Others were built to have different timing, faster onset, shorter duration, cleaner wake-ups. The names that matter here aren't street myths, they're instruments, compounds engineered for the anesthesiologist's hand. And then there's the shadow lineage, analogues that appear not because they're needed medically, but because they're useful commercially in a prohibited market. Useful because they can be synthesized from available precursors. Useful because they can be shipped in tiny amounts. Useful because they might not be listed on a schedule yet. Useful because they can be sold as something else. This is where policy runs into chemistry. Controlled substance law is built around list schedules, named compounds, classifications that assume the threat is stable and identifiable. But the fentanyl scaffold is adaptable. If you can change a group here, swap a substitution there, you can create a new compound that may still hit the same receptor with lethal force while sitting in a gray zone until regulators catch up. In the United States, lawmakers tried to address this with the Federal Analog Act in the 1980s, a law meant to treat substantially similar substances as illegal when intended for human consumption. It was an attempt to close a loophole. It helped in some cases. But it also created a new battlefield. Similarity is not a simple word in a courtroom. Chemists argue in structures. Prosecutors argue in intent. Judges and juries are asked to evaluate technical claims while people keep dying in the meantime. And as the 2000s rolled into the 2010s, the analog problem stopped being an occasional flare-up and became part of the baseline reality. The list of names grew: long acetyl variants, butyl variants, fluorinated variants, ring-modified variants, each one a small twist on the same deadly logic. Some changes increased potency, some changes altered metabolism, some changes affected detectability, meaning the compound might not show up on routine toxicology screens. That last point matters more than most people realize. For years, many hospitals and clinics relied on immunoassay screens for opioids tests designed to detect common classes of drugs. Those tests often missed fentanyl entirely, and they were even less reliable for novel analogues. So the early evidence of what was happening arrived indirectly. Overdoses that didn't match the heroin patterns clinicians expected, cases requiring multiple doses of naloxone, clusters of deaths where the drug found on the scene didn't explain the severity. The lag between reality and detection created blind spots. Public health surveillance undercounted. Communities underestimated risk. People used their usual amount of what they thought was a familiar drug, and the margin for error collapsed. Then there are the outlier compounds, the ones that should never have left specialized contexts. Fentanyl is the clearest example, and it's worth lingering on because it illustrates what potency means when you stop speaking in abstractions. Fentanyl was developed as a veterinary immobilizer for large animals. The scale of its intended use is not human, it's elephants. And when that scale collapses down into a street drug context, the result is obscene. Doses measured in micrograms that can shut down breathing with terrifying speed. Fentinel's notoriety seeped into public consciousness in part because of a geopolitical tragedy. During the 2002 Moscow theater hostage crisis, an aerosolized opioid agent, later linked to fentanyl derivatives, was used to incapacitate hostage takers. Many hostages required emergency medical care. More than 100 died, many from respiratory failure. Whether one calls it counter-terrorism or catastrophe, the lesson was the same. High-potency opioids behave like weapons when deployed without careful medical support. And in the illicit supply, weapon-like effects can appear without intention. Not because a dealer wants deaths, though some are indifferent, but because the manufacturing and mixing process is inherently unstable when profit outruns quality control. That instability is structural. A kilogram of heroin is bulky. It has smell, volume, and handling characteristics that constrain how it moves. A kilogram of fentanyl powder, depending on purity and intended dosage, can represent a staggering number of doses. It fits into smaller shipments. It reduces trafficking risk. It increases profit margins. It makes global logistics an accomplice. That is why the supply chain pivoted. By the mid-2010s, illicit manufacturing wasn't primarily a story of stolen patches or diverted hospital vials, though that still happened. It became a story of industrial-scale synthesis, precursor chemicals, pill presses, and cross-border networks that could adapt faster than a regulatory agency writes a rule. For years, Chinese chemical manufacturers, some legitimate, some operating in legal ambiguities, played a significant role in the flow of fentanyl and precursor chemicals. The internet made it easier to connect buyers and sellers. Parcel shipping made it easier to move small, potent quantities across borders with less scrutiny than bulk shipments. A package that looks like ordinary commerce can carry enough powder to supply a city. Mexico's criminal organizations recognized the math quickly. They had the infrastructure, experienced trafficking routes, laboratories, chemists, smuggling networks, corruption channels, distribution networks inside the United States. And fentanyl offered three irresistible advantages: cheaper production than heroin, smaller shipments for higher value, and easy integration into existing markets, either as an additive or a replacement. At first, fentanyl was often mixed into heroin to boost potency or stretch supply. Then counterfeit pills became the most efficient format. Counterfeit tablets are a perfect intersection of deception and scale. A pill press can produce thousands of tablets quickly. The tablets can be stamped with familiar imprints, numbers, and logos that suggest a legitimate prescription drug. The color, size, and shape can mimic what people believe they are buying. And the contents can be wildly inconsistent. This is the point where the crisis changes character. When fentanyl spreads through a heroin market, the people most exposed are primarily opioid users. When fentanyl spreads through counterfeit pills, the exposed population broadens dramatically. A teenager buying what they believe is a prescription stimulant. A person seeking a real oxycodone. Someone experimenting casually, trusting a tablet because it looks pharmaceutical. The counterfeit pill turns the illicit market into a minefield because appearance stops being a reliable guide. And the manufacturing reality behind those pills is not precision, it's approximation. Powder distribution can be uneven. Mixing can be sloppy. One pill in a batch can carry a dose that feels mild, the next can carry a dose that kills. The press makes the deception uniform while the chemistry remains chaotic. Law enforcement responded with the tools it had: seizures, arrests, interdiction, diplomatic pressure, and increasingly class-wide scheduling. Regulators attempted to freeze entire families of fentanyl-related substances rather than naming individual compounds one by one. The logic was simple: stop the endless whack-a-mole. But every enforcement move creates incentives for adaptation. When China announced class-wide controls on fentanyl-related substances in 2019, it altered some supply routes. It slowed certain direct exports. It changed the visible landscape. It did not end the market, it pushed it. Production shifted, precursors were rerouted. Synthesis moved closer to consumer markets. Different intermediates appeared. The supply chain learned, as it always does, to look for the next open window. Meanwhile, toxicology improved. Public health surveillance systems began investing in better detection. Coroner and medical examiner offices expanded LC-MS capabilities in some regions. Overdose reporting improved in others. But the lag remained, especially in underfunded jurisdictions, rural counties, overwhelmed city systems, places where the crisis was deepest and resources were thinnest. And while labs and laws were catching up, people were dying in patterns that had a distinct signature: rapid collapse, repeated naloxone doses, clusters of deaths linked to counterfeit pills or contaminated stimulants, a widening demographic spread that made it harder to keep telling the story as someone else's problem. In Part 5, we'll follow that signature into the data and into the streets. How fentanyl reshaped overdose epidemiology. Why polysubstance use became the rule rather than the exception. How naloxone, test strips, and supervised consumption sites emerged as practical responses. And why none of these tools can succeed without the less glamorous infrastructure: treatment access, housing stability, and systems built for people rather than headlines. By the mid-2010s, the crisis stopped behaving like a slow-moving scandal and started behaving like weather. Not in the sense that it was natural, it wasn't, but in the sense that it became ambient. It was everywhere at once, changing the feel of ordinary life in ways you can't capture in a single graph. A missed shift, a kid's backpack packed in a hurry, a library bathroom checked too often, an EMT crew carrying more naloxone than bandages, a city budget quietly reshaped by overdose calls the way coastal budgets are reshaped by storms. Public health agencies can tell this story with numbers, and the numbers are grim. Synthetic opioids rose year over year, and in many places became the dominant driver of opioid mortality. But the data also tells a subtler story, if you look long enough. Fentanyl didn't just increase the count, it altered the structure of the epidemic. Earlier waves of opioid harm were shaped by prescription patterns and heroin markets. There were predictable demographics, more predictable geographies, a familiar rhythm in how people entered and stayed in use. Fentanyl changed the rhythm because fentanyl changed uncertainty. First, it accelerated time to collapse. Clinicians and harm reduction workers began reporting that overdoses happened faster. People would use and become unresponsive within minutes. That speed matters. It means fewer chances for someone to notice, fewer chances for rescue, fewer chances for a person using alone to survive at all. Second, it widened exposure beyond traditional opioid users. Fentanyl didn't stay in opioids. It entered stimulant supplies. Cocaine, methamphetamine, counterfeit pills sold as benzodiazepines, or prescription stimulant substances used by people with no opioid tolerance, people with no expectation that an opioid was present. This is one of the quiet catastrophes of the fentanyl era: risk without consent, potency without warning. Third, it increased the complexity of overdoses. Polysubstance use became a dominant pattern: an opioid plus alcohol, an opioid plus benzodiazepines, an opioid plus stimulants. These combinations are not new, but fentanyl made them more lethal and more confusing to treat. A person might appear overstimulated, agitated, tachycardic, until the opioid component suddenly wins and breathing fades. Emergency clinicians began encountering cases where the clinical presentation didn't match a single drug category. It matched the modern supply, mixtures. These shifts also created measurement problems. Many jurisdictions were not equipped, at first, to detect fentanyl analogs reliably. Some death investigations listed opioids or narcotics without specific identification. Some medical examiner offices had limited access to advanced toxicology. Some regions underreported for years simply because they lacked lab capacity. So epidemiologists learned to triangulate: EMS naloxone administrations, emergency department overdose visits, law enforcement seizure data, toxicology where available, and increasingly, near real-time public health reporting systems. The picture that emerged was consistent even when the details were fuzzy. Fentanyl had become a dominant contaminant and, in many markets, a dominant product. Geography mattered too, but not in the comforting way geography usually matters. In the United States, early spikes were pronounced in parts of the Northeast and Midwest, places where heroin markets were established and where economic dislocation had already stressed communities. Certain cities saw sharp early increases. Certain counties became epicenters. Then the wave broadened. Rural areas were not spared. Regions that had been hollowed by deindustrialization, places with fewer jobs, fewer clinics, fewer mental health resources, often carried disproportionate harm. In Canada, British Columbia's overdose emergency declaration in 2016 became an unmistakable signal. Vancouver's downtown east side, already familiar with public drug use, HIV risk and deep poverty, was hit hard. Ontario followed its own arc. The crisis was national, but it expressed itself locally. Each province and city shaped by different supply patterns, different responses, and different social safety nets. Demographics shifted in ways that complicated simplistic narratives. Early opioid waves in the US were often framed as a crisis in white, non-Hispanic communities, especially in certain age groups. As fentanyl saturated broader drug markets, fatality rates rose sharply in Black and Latino communities in many urban settings, and among younger adults exposed through counterfeit pills. The crisis became less about one population and more about a toxic supply environment interacting with vulnerability, economic, medical, social. And vulnerability isn't only personal, it's structural. Where treatment access was scarce, overdoses were more likely to recur. Where housing instability was common, people used in riskier environments. Where stigma was intense, people used alone. Where healthcare was expensive or distrusted, people delayed seeking help. Where policing was aggressive, people rushed consumption to avoid detection. Another small behavioral change that increases overdose risk. Fentanyl is not forgiving about rush dosing. So communities began building responses that weren't philosophical. They were logistical. Naloxone distribution scaled up because it had to. Naloxone is an opioid antagonist. It knocks opioids off receptors, buying time by restoring breathing. It works. But fentanyl created a practical reality that responders learned quickly. Reversals often required multiple doses, and rescue depended as much on ventilation as on medication. A person revived with naloxone can slip back into overdose if the opioid burden in the body outlasts naloxone's effect. Rescue is not a moment, it's a sequence. Policy shifted to match that reality. Standing orders expanded pharmacy dispensing. Good Samaritan laws aimed to reduce the fear of calling 911. Schools and libraries began stocking naloxone. Police departments carried it. Community organizations trained families. The antidote became normalized, an unglamorous, life-saving tool distributed with the urgency of a fire extinguisher. And then came harm reduction tools that, a decade earlier, many politicians would not say out loud on camera. Fentanyl test strips. Simple immunoassays that can detect fentanyl in a dissolved sample became widespread in outreach work. They are not perfect. They don't quantify dose. They can miss certain analogs. They can produce false reassurance if used incorrectly. But they offer something critical, information before ingestion. And evidence from multiple settings suggests people change behavior when they know fentanyl is present. Using less, using with someone nearby, avoiding a particular batch, carrying naloxone. Drug checking expanded beyond strips in some places. Portable spectrometers, mass spectrometry in supervised sites, data sharing networks that could issue alerts. This batch contains X. This powder contains fentanyl plus unexpected sedatives. Counterfeit pills with this marking have been linked to overdoses. These systems are not magic. They are infrastructure. They require staff, equipment, funding, trust, and real-time communication. Where that infrastructure existed, communities often did better, not because they eliminated drug use, but because they reduced the fatality rate of the environment. Supervised consumption sites, places where people can use drugs under medical observation, became one of the most contentious interventions and one of the most evidence-supported in contexts where they were allowed to operate. These sites don't solve addiction. That's the wrong question. They reduce death. They reduce public use. They provide connections to healthcare, wound care, testing, and sometimes treatment. They also confront the most lethal variable in overdose, using alone. But politics is rarely guided by the most lethal variable. It's guided by symbols. In some jurisdictions, supervised sites were treated as an admission of defeat. In others, they were treated as triage-like field hospitals during an epidemic. The same split-shaped syringe service programs, which reduced infection risk and provided a point of contact for care. Where these programs were embraced, HIV and hepatitis transmission often fell, and overdose response improved. Where they were blocked, harms piled up quietly until they were visible in hospital wards. Treatment access remained the central, stubborn axis. Methadone and buprenorphine reduce mortality for opioid use disorder. The evidence is strong. The barriers were not scientific, they were regulatory, cultural, and geographic. In many places, methadone clinics were scarce or stigmatized. Buprenorphine prescribing was restricted by training requirements and caps for years. Even when restrictions loosened, workforce capacity lagged. People seeking treatment often encountered waiting lists, transportation barriers, insurance problems, or a simple lack of clinicians willing to treat them. And in the fentanyl era, waiting list can be another word for risk. Some systems adapted. Emergency departments began initiating buprenorphine. Telemedicine expanded, especially during the COVID era, when rules were relaxed out of necessity. Outreach teams began offering low-threshold pathways into care. Fewer hoops, fewer punishments, more continuity. These approaches weren't perfect, but they recognized a reality that moralizing policies ignore. People can't recover if they don't survive. The fentanyl era also introduced a new complication that naloxone doesn't solve: non-opioid adulterants with sedative effects and severe health consequences. You can reverse an opioid component and still face prolonged sedation, wounds, infections, and long-term disability. This is where the crisis stops looking like a single drug problem and starts looking like a collapse in the safety of the entire unregulated supply. And that brings us to the hard truth that sits beneath every intervention. None of this works at scale without addressing the context people live in. Housing matters, jobs matter, trauma care matters, mental health care matters. The ability to see a doctor without humiliation matters. The ability to enter treatment without losing everything matters. Fentanyl amplifies pain, but it didn't invent despair, it exploited it. In Part 6, we'll move into that broader context: the social and economic toll, child welfare systems strained, hospitals flooded with infection and injury, communities frayed by stigma. And then we'll track the policy response as it splits: enforcement versus public health, border rhetoric versus clinic logistics, headlines versus outcomes, because this crisis has always been fought on two stages at once: the stage people see on television and the stage where people actually survive. In the fentanyl era, the public often measures the crisis in death counts because death counts are what make headlines. But communities live it in quieter ledgers. A county child welfare office with a waiting room that never empties. A grandmother raising 2 kids with a fixed income and a worn-out car. A small-town ER that becomes, night after night, the de facto mental health clinic, detox center, and trauma unit. A probation officer managing a caseload that looks less like criminality and more like untreated illness paired with unstable housing. A school counselor keeping a drawer of snacks and naloxone because both are, in different ways, tools for survival. Fentanyl didn't create these fragile systems, it pushed them until they cracked. Families absorbed the most intimate costs. When someone dies of an overdose, the story doesn't end at the funeral. It continues in bills and paperwork and sudden responsibilities. It continues in the way siblings move through school with a new silence. It continues in the way parents learn to speak about grief in code because straight language feels too sharp for everyday life. Stigma adds another layer of damage. In many places, addiction is still treated as a moral failure first and a medical condition second. That moral framing doesn't just hurt feelings, it shapes policy. It reduces funding. It keeps treatment clinics out of neighborhoods. It discourages people from asking for help early. And it teaches families to hide what is happening until it becomes impossible to hide. One of the most visible stress points has been foster care and child welfare. In many jurisdictions, rising substance use disorder has been linked to increased child removals, increased kinship placements, and caseloads that overwhelm already strained social workers. When parents are unstable because of use, because of incarceration, because of untreated mental illness, compounded by a toxic supply, children become the fragile cargo passed from system to system. In communities already carrying historical trauma, the consequences are amplified. Indigenous communities in Canada and the United States often experience overdose rates that exceed the general population, shaped by layered factors: poverty, inadequate healthcare infrastructure, jurisdictional complexity, and intergenerational harms of colonization. Meanwhile, in many US cities, Black and Latino communities face the double burden of fentanyl's spread and a criminal legal system with a long history of punitive responses to drug use. The crisis lands on top of existing inequities and then deepens them. Hospitals carry the financial and clinical strain in ways that don't translate well into political speeches. Emergency departments see the acute side: overdose reversals, agitation, withdrawal, trauma, psychiatric crises. But inpatient units see the long tail: infections associated with injection drug use, prolonged hospitalizations, wound care, endocarditis that can require valve surgery, repeated admissions. These cases are expensive, complex, and emotionally draining for staff. Rural hospitals, often operating on thin margins, are particularly vulnerable. A handful of long admissions can destabilize a budget that was already barely holding. First responders bear another set of costs, and not only the cost of naloxone, they absorb trauma. Repeated exposure to death and near-death changes people. Paramedics and firefighters describe a kind of moral fatigue. The feeling of reviving the same person multiple times, wanting them to live, but also watching the system fail to offer stable treatment pathways afterward. Police officers, too, are pulled into roles they weren't trained for: medical response, social triage, while still operating under enforcement mandates that can undermine public trust. This is what a crisis looks like when it becomes normal. And when a crisis becomes normal, policy becomes theater, unless it is anchored to outcomes. The fentanyl era produced two major policy impulses that often ran side by side without touching: enforcement escalation and public health expansion. In speeches, leaders promised both. In practice, jurisdictions tended to emphasize one or the other, depending on politics, budgets, and culture. Enforcement escalation is emotionally intuitive. It offers villains. It offers seizures photographed on folding tables. It offers press conferences where officials hold up bags of powder like trophies. And it offers a simple storyline: stop the supply, stop the deaths. But supply suppression is a complicated instrument. Sometimes it works locally and temporarily. Sometimes it creates shortages that push people into withdrawal and riskier behavior. Sometimes it drives the market toward more compact and potent products, an effect observed in multiple drug prohibition contexts. When it becomes harder to move bulky drugs, traffickers favor potent concentrates that are easier to conceal. Fentanyl's compactness makes it particularly suited to this dynamic. Interdiction can force adaptation rather than elimination, and adaptation can increase danger. Class-wide scheduling, emergency DEA actions, and international pressure on precursor supply have all been used. Some of these measures constrained certain flows and complicated illicit manufacturing. But none of them solved the demand side: why people use, why they can't access treatment, why communities lack mental health care and housing. Enforcement can disrupt supply. It rarely builds recovery infrastructure. Public health expansion, by contrast, is less cinematic and more effective when done at scale. It looks like naloxone distribution programs with consistent funding. It looks like medication for opioid use disorder treated as standard care rather than a specialty service. It looks like low-threshold clinics, telehealth initiation, and stable follow-up. It looks like harm reduction services integrated into healthcare rather than pushed to the margins. It looks like data systems that detect spikes quickly and issue alerts fast enough to matter. But public health measures require political courage because they force a society to admit that people use drugs whether or not the law approves, and that saving lives sometimes means meeting people where they are rather than where we wish they were. This is where the headline story and the outcome story diverge. Headlines reward outrage and simplicity. One pill can kill, monsters at the border. Dealers as the primary cause, users as either victims or villains. Outcomes reward logistics, clinic hours, referral pathways, housing vouchers, trained staff, access to buprenorphine, retention in care, overdose prevention education, data sharing, And yes, targeted enforcement against large trafficking networks, rather than broad punitive sweeps that fracture communities. Media coverage helped in some ways. It raised awareness, it spurred funding, it pushed naloxone into mainstream discussion. But it also hardened stigma and encouraged fear-driven policies. Sensational narratives can make communities less safe by pushing use into hidden spaces and making people hesitate to call for help. The healthiest public messaging in this era has tended to be the least dramatic. It tells people how to survive, not how to panic. Carry naloxone. Don't use alone. Test your supply if you can. Start with less. Understand that counterfeit pills are common. Seek treatment if you want it, and know that relapse is not failure. It's a feature of how addiction behaves. These messages don't flatter political instincts, but they reduce deaths when paired with real services. And now we reach the next crucial pivot. Once fentanyl became embedded in the supply, the crisis stopped being only about opioids. Adulterants and co-occurring drugs began shaping outcomes. Sedatives not reversed by naloxone began appearing more frequently in certain markets, complicating rescue and long-term medical care. Stimulant use rose in many regions, and fentanyl contamination made stimulant use more lethal. The opioid crisis became in practice an overdose crisis polysubstance, unstable, evolving faster than most institutions. So the response had to evolve too. Forensic labs modernized, sometimes slowly, sometimes rapidly. Public health surveillance shifted toward near real-time tracking. Wastewater monitoring gained relevance in some regions. Community organizations built alert networks. Hospitals updated protocols, training staff to expect repeat naloxone dosing and to prioritize ventilation. Emergency departments increasingly initiated buprenorphine and built referral relationships with outpatient treatment. Some jurisdictions experimented with safer supply policies, controversial but pragmatic, reducing exposure to the poisoned illicit supply by offering regulated alternatives in controlled settings. None of these are clean solutions. They are triage and reconstruction happening at the same time. In Part 7, we'll move into the policy future, the branching paths ahead, punitive escalation, decriminalization and treatment, safe supply experiments, new pharmacological tools like antibodies or vaccines, and the hard, unglamorous conclusion that has held across every chapter of this story. No single lever fixes a crisis that was created by many levers at once. If you listen closely to the last decade of debate, you can hear the same argument repeating itself with different costumes. One side says, tighten control, more interdiction, more penalties, more pressure upstream. If you choke supply hard enough, the market collapses and with it the body count. The other side says, treat the cause, not only the symptom. Expand medication treatment, normalize harm reduction, build systems that keep people alive long enough to recover. If you reduce deaths and stabilize lives, demand changes, and the market loses its customers. Both sides touch something true. Both sides often ignore something crucial. Because fentanyl is not a single problem. It's an ecosystem problem. It's chemistry meeting commerce. It's pain meeting policy. It's an unregulated supply meeting human vulnerability. It's a product category meeting a country with uneven healthcare access. And it's a set of decisions regulatory, corporate, clinical and personal compounding over time until the curve steepens. So when we talk about the future, what we're really talking about is which ecosystem we build next. One plausible future is escalation by adaptation. In this future, enforcement continues to tighten around known fentanyl analogs and known precursor pathways. Illicit producers respond by shifting to other synthetic opioids that occupy the same market niche. Cheap, potent, easy to ship, and not always detected quickly. The drug supply remains unstable, and the public keeps playing chemical roulette. We've already seen hints of this logic. When one compound becomes too visible, another emerges. Sometimes the substitute is not even a fentanyl analog. Sometimes it's a different synthetic class entirely. New names, new risks, same outcome, unpredictable potency in an unregulated market. A second plausible future is fragmentation. Instead of a few dominant producers, production becomes more decentralized. Smaller labs, smaller networks, more variability. Knowledge and equipment are widely available. Precursors can be sourced through layered supply chains, and distribution can be arranged online with the anonymity of encrypted platforms. This future is harder to police because it has fewer choke points. It's also more dangerous for users because quality control deteriorates further as the supply becomes patchier. A third future is the one public health professionals keep trying to build: stabilization. In this future, the goal is not to pretend drug use will vanish. The goal is to make death less likely and recovery more accessible. It's a future built on boring victories: clinic capacity, retention in care, housing, mental health services, and harm reduction integrated into healthcare rather than treated as a political dare. The stabilization future has several concrete components. First, medication for opioid use disorder at scale. Methadone and buprenorphine are among the most evidence-supported tools we have for reducing overdose mortality. In regions where these medications are accessible without excessive hoops, deaths fall. Where they are scarce, deaths rise. Stabilization means removing barriers. It means making initiation possible in emergency departments, primary care clinics, mobile units, and through telehealth where appropriate. It means training clinicians as a standard part of medical education rather than treating addiction care as a niche. It means paying for care reliably, including counseling and peer support where it helps, without making perfect compliance the price of admission. Second, naloxone saturation. This is the fire extinguisher principle. If overdoses are common, naloxone must be common. Not only carried by EMS and police, but in homes, shelters, libraries, schools, bars, and community centers. And paired with education that is practical rather than moralizing: how to recognize an overdose, how to administer naloxone, how to ventilate, when to call for help, and what to do after revival. Third, harm reduction as infrastructure. Syringe services, drug checking, outreach, supervised consumption in jurisdictions willing to implement it, wound care, hepatitis and HIV testing, linkage to treatment, basic supplies, and trained peers. These are not boutique programs. They are the ground layer that makes everything else possible. They also produce intelligence. Not police intelligence, public health intelligence. Which batches are circulating, which adulterants are appearing, where overdoses are clustering. That information, shared quickly, can save lives. Fourth, a deeper response to the social determinants that make overdose likely. Stable housing reduces risk. Employment and income stability reduce risk. Trauma-informed mental health care reduces risk. Reducing the churn of incarceration reduces risk. If you want fewer overdoses, you need fewer people forced to live in conditions where overdoses are likely. This is where policy gets uncomfortable because it requires investments that don't look like drug policy. They look like housing policy, healthcare policy, labor policy, education policy, and those investments are slower than a press conference. They don't produce instant victory shots, but they change the slope over time. There's also a branch of the stabilization future that remains controversial and, in some places, experimental: safe supply. The logic is blunt. If the illicit supply is poisoned and unpredictable, one way to reduce deaths is to provide a regulated alternative to people at the highest risk pharmaceutical-grade substances with known dosing, provided under medical supervision and paired with services that support stabilization. This idea alarms many people because it sounds like endorsement, but it can be understood as triage. Reduce exposure to a lethal market while building pathways to treatment and recovery. It does not eliminate addiction. It reduces overdose risk and can improve engagement with healthcare for some individuals. Safe supply is not simple. It requires careful design to avoid new diversion streams and to ensure that it's paired with support rather than functioning as a standalone medication vending machine. Evaluations to date show mixed results depending on the model, the population, and the surrounding services. But it remains on the table because the alternative, continuing to feed people into a poisoned market, has not been acceptable. Meanwhile, science is trying to offer new tools. Better analgesics are being pursued to reduce reliance on classic opioids. Multimodal pain management is gaining ground: nerve blocks, non-opioid medications, physical therapy, behavioral approaches, methods that can reduce opioid exposure without denying pain. And more futuristic tools are being explored. Monoclonal antibodies designed to bind fentanyl-like molecules in the bloodstream, and vaccine approaches that might induce the body to produce antibodies that prevent the drug from reaching the brain. These ideas are real. They've shown promise in early research. They also raise complex questions. If you vaccinate someone against fentanyl, what happens if they later need opioids for surgery? If you use antibodies in the field, how do you deploy them safely and affordably? Who receives them? Under what consent framework? And how do you avoid creating new inequities where the most vulnerable are offered experimental solutions while stable care remains unavailable? Science can build tools. It cannot build trust by itself. Regulation faces its own paradox. Broad scheduling can slow the introduction of new analogs, but it can also complicate legitimate research by making it harder for laboratories to obtain reference standards and conduct studies. If you strangle research in the name of enforcement, you lose your ability to understand and anticipate the next wave. A mature policy needs both: rapid control of high-risk substances and streamlined pathways for legitimate scientific work. International cooperation remains indispensable, but it must be paired with realism. When one country tightens controls, production shifts. When one precursor is scheduled, chemists find another. When one shipping route is monitored, traffickers use a different one. Supply-side policy is not useless, it's necessary, but it is not sufficient. It buys time, it can raise costs. It can disrupt certain networks. It cannot on its own rebuild the conditions that make people vulnerable. And so, the future splits into a set of choices that are less dramatic than the headlines imply. Do we build systems that keep people alive and offer real treatment without humiliation? Or do we continue to treat the crisis as primarily a criminal narrative, responding to death with punishment and hoping chemistry eventually runs out of tricks? Do we invest in the boring infrastructure, clinics, housing, data systems, trained staff? Or do we invest mainly in visible force and accept the churn as the cost of doing business? The fentanyl era has taught an ugly but useful lesson. Moral clarity is not the same as practical effectiveness. The best interventions are often emotionally unsatisfying. They don't feel like victory. They feel like maintenance, like keeping someone alive long enough for their life to change. And that brings us back to the place we started. A molecule doesn't care about our intentions. It doesn't care about our politics, or our shame, or our speeches. It binds, it diffuses, it activates receptors, and it changes breathing. What we control, what we actually control, is the context we build around it. The medical systems, the regulatory systems, the social systems, the availability of treatment, the honesty of marketing, the speed of surveillance, the compassion of public policy, and the stubborn willingness to do work that isn't glamorous, but is life-saving. In Part 8, we'll close this arc by pulling the threads together. The bench, the bedside, the boardroom, the border, the street. How they connect. What the story gets wrong when it's told as a single villain. And what the Forbidden Dispensary thinks the quiet takeaway should be when the screen goes dark and the room gets quiet again. There's a temptation, when a story gets this big, to look for one clean cause. One bad actor, one policy mistake, one border, one corporation, one cartel, one molecule. That temptation is understandable. It's how the mind protects itself from complexity. It chooses a single target, then calls that target the problem. Because a single target can be hated, punished, defeated. A system cannot be punched. But fentanyl, in the rough spelling we're carrying tonight, doesn't fit into a single target. Not honestly. Not if you want an explanation that holds up after the adrenaline of outrage fades. If you trace the arc from the beginning, you see the braid. A Belgian lab in the mid-20th century, chemists chasing control over pain with the optimism of an era that believed chemistry could solve almost anything. A compound engineered to be fast and powerful in clinical hands. Patents, early studies, anesthesia evolving into a discipline that valued precision and predictability. And for decades in that context, fentanyl was a tool dangerous if mishandled, but valuable when respected. Then the molecule expands into products. Patches and transmucosal formulations promise steadiness, dignity, rapid relief, convenience. Many of those promises are real. They eased suffering. They made certain lives bearable. They also created new interfaces between a microgram-level drug and ordinary human behavior, new ways for mistakes to happen, new opportunities for diversion, new markets to be built. Then the culture around pain shifts, and commerce meets that shift with practiced skill. Messaging emphasizes compassion and control, sometimes while underplaying long-term risks. Policy lags and then overcorrects. Prescribing expands and then constricts. Patients get stabilized and then cut off. Some people fall into the illicit supply, and the illicit supply is not stable, it is not measured, it is not merciful. Then illicit chemistry industrializes. Precursors, labs, pill presses, counterfeit tablets, global shipping. The drug becomes compact enough to move like email, potent enough to turn a minor deception into a death sentence. It spreads beyond opioid users into stimulant users and casual pill buyers. It becomes ambient risk. Then public health begins improvising defenses. Naloxone saturation, test strips, drug checking, supervised use where allowed, data systems that try to see the wave before it breaks, and treatment access fought for in legislatures, clinics, and courtrooms. Enforcement escalates too, sometimes with targeted success, sometimes with predictable displacement effects. International cooperation tightens one route and opens another. Chemistry adapts, policy adapts. People keep dying. If you're looking for the real villain in this story, you're going to end up disappointed because villains imply intention and coherence. The crisis is less coherent than that. It's an emergent property of interacting forces. That doesn't mean there's no accountability. There is accountability everywhere. Corporate decisions that favored sales over caution, marketing that blurred boundaries, prescribers who treated opioids as low risk for long-term use, regulators who moved slowly, policymakers who treated addiction primarily as criminality, healthcare systems that rationed treatment, insurers that refused coverage, employers that discarded injured workers, communities that pushed clinics away, and a society that was willing to fund punishment more readily than care. Accountability is not the same thing as a single villain. It's distributed. And distributed accountability is harder because it asks more of us. It asks for reform instead of revenge. It asks for the slow crafts. Clear labeling, secure storage, proper disposal, honest education, trained clinicians. Easy entry into medication treatment without shame or delay. Data systems that connect EMS calls to public health alerts to outreach networks. Harm reduction treated as standard care. Housing and mental health support treated as overdose prevention because they are. Enforcement focused on the networks that profit most, not the people already losing everything. It asks for humility too, because part of what makes the fentanyl era so brutal is that it punishes overconfidence. It punishes the belief that we can dominate pain without cost. It punishes the belief that a patch or a pill can substitute for a stable life. It punishes the belief that a law is the same as a solution. It punishes the belief that if we just say no loudly enough, chemistry will stop moving and markets will stop adapting. A molecule doesn't care what we believe, it only does what it does. And that's the last quiet lesson I want to leave on the table tonight. The history of fentanyl is often told as a collapse from miracle to plague. But that's not quite right. It's more accurate to say it's a story about precision escaping its intended boundaries. A tool built for monitored rooms, becoming a commodity in unmonitored markets. Micrograms leaving systems designed to count them, and entering systems designed to profit from them. When that happens, everything becomes fragile. The user, the family, the first responder, the clinic, the courthouse, the city budget, the public conversation. So if there's a takeaway that isn't a slogan, it's this. Treat fentanyl like what it is, an amplifying force. In medicine, it amplifies analgesia and anesthetic control and demands respect. In illicit supply, it amplifies risk and demands harm reduction. In policy, it amplifies the consequences of delay and the consequences of cruelty. It reveals where a system is weak because it finds the weakness and turns it lethal. And because it's an amplifying force, the response has to be layered. Not one program, but many. Not one law, but a framework. Not one speech, but sustained funding. Not one heroic intervention, but everyday access to care. Everyday distribution of rescue tools, everyday human contact that keeps people tethered to life. That's not a satisfying ending. There's no cinematic closure. There's no final villain dragged into the light while the music swells. There's just the slow work of building a safer context around an unsafe chemistry. At the Forbidden Dispensary, we don't tell these stories to scare you for entertainment. We tell them because understanding changes behavior, and behavior changes survival. If you're a clinician, it changes how you prescribe and monitor. If you're a policymaker, it changes what you fund. If you're a family member, it changes what you keep in the house and how you talk about help. If you're someone who uses, it changes how you reduce risk and how you reach for treatment when you're ready. And if you're just a person watching late at night, it changes what you recognize when the world tries to flatten a complex tragedy into a simple headline. That's where we'll end for tonight. If you want, tell me in the comments what part of this story you think gets misunderstood most often. Science, medicine, marketing, policy, or the human cost. And if you're listening from a place that's been touched by this crisis, I'm not going to ask you for details. I'm just going to say, I'm sorry and I hope you stay with us. Good night.